Okay, so I think we're going to go ahead and get started. Thank you again, everyone, for joining for our NHRC lecture series today with our topic on chronic pulmonary hypertension in preterm infants. My name is Rachel. I'm a clinical assistant professor at the University of Iowa in neonatology and neonatal hemodynamics, and I'm very happy to get to be co-moderating with Dr. Phil Levy, a neonatologist and cardiology and hemodynamics experts from Boston Children's. So I'll let Phil take it away and introduce the session.
Thank you so much, Rachel. It's great to have everybody here. Close to 150 people from around the world, and just appreciate everybody. If you got up early or you're staying up late today, we have a great session planned. It's my real honor and pleasure to introduce Rachael Hopper, who is a phenomenal pediatric cardiologist and a specialist in the care of children with pulmonary hypertension. She clinical professor of pediatrics and is the associate director of the pediatric pulmonary hypertension program at Stanford. She has a real special interest in pulmonary hypertension associated with prematurity. And I think the first time I heard her speak, I thought she was actually a neonatologist with how well she had mastered the topic. She also co-directs the multidisciplinary cardiac and respiratory care for infants with BPD, or the CRIB program at Stanford. And today, I think I personally am excited to learn from her over the next 30 minutes. After her talk, we will have an exciting panelist discussion, and we'll introduce our panelists after Rachael Hopper speaks. Rachel, the floor is all yours, and thank you so much.
My pleasure. Thanks so much for the invitation. As you noticed, Phil, neonatologists are near and dear to my heart. My father's a neonatologist, so I probably couldn't help being exposed to neonatology early in life, and it's really something I enjoy and continues to challenge me. So today, I was tasked with talking about chronic pulmonary hypertension. So we'll talk a bit about screening and phenotyping, and then sort of how I follow these kids longer term. No disclosures. Of course, everything we do in PH and infants is off-label, so there will be discussion of off-label use of medicines. And just by way of introduction, when I think about PH in infants, abnormal lung development is a major driver. It's not the whole story, but it's a large part of the story. So we'll talk through some disordered lung development and how that relates to pulmonary hypertension. We'll talk a bit about dedicated screening, go through the guidelines and our practice here at Stanford, and then we'll talk about how multifactorial this is and how we approach phenotyping and how that influences our approach to therapy. So just to start off, I always like to talk a little bit about the definition of pulmonary hypertension, because the definitions we used were really designed for adults. They work in kids with some caveats. So pulmonary hypertension in general, regardless of the etiology, is defined as a mean pulmonary artery pressure greater than 20 millimeters of mercury, and that's a cath definition. That can include pulmonary vascular disease, that includes shunts, that's all comers, elevated pulmonary artery pressure. And most of the time in my world, when I see kids with pulmonary vascular disease, we're talking about pre-capillary pulmonary hypertension, pulmonary arterial hypertension, which is an elevated mean pulmonary pressure with a normal wedge pressure, and you'll see I put a little red asterisk there because the definition for adults is a wedge pressure less than 15. And even in the adult world, at the most recent World Symposium, there was a lot of back and forth about whether or not 15 was too high as a cutoff. And certainly for infants, 15 is too high as a cutoff. So in my practice, I think of more of a wedge pressure greater than 10 as being abnormal in infants. And that's important to tell you about left-sided post-capillary pulmonary vascular disease. And of course, we use the pulmonary vascular resistance index of greater than 3. The adults changed their criteria to be greater than 2, but because we index everything to body surface area in kids, there was the consensus of the most recent World Symposium that we should keep this pulmonary vascular resistance index greater than 3 as our definition. Of course, both babies and adults can have post-capillary pulmonary hypertension from left-sided heart disease or left-sided obstruction. And this, the difference here clearly is an elevated wedge pressure and a normal pulmonary vascular resistance. Some patients, unfortunately, end up with a mixed phenotype where they have an elevated wedge from left-sided heart disease, but also develop elevated pulmonary vascular resistance. And those patients are especially challenging to treat. So this is the classification we love to talk about for pulmonary hypertension that was just updated this summer at the most recent World Symposium. Paul and I were fortunate enough to be there in Barcelona. And really, there weren't a lot of huge changes as pertaining to pediatric disease. I highlighted in sort of the brighter blue here the categories that we think about in terms of chronic pulmonary hypertension. And I think this is important because we see a lot of this in older kids, but we also see these this sort of spectrum of disease in infants, certainly congenital heart disease related PH, some of the heritable or genetic conditions, left-sided heart disease, of course, and developmental lung disease. And it's all well and good to have 5 distinct categories, but the reality, as we all know, is that kids really don't read the textbooks, and it's often much less clear. What we often see is that some kids have a genetic predisposition. They may have abnormal lung development relating to that. There may be postnatal injury from shunts, from inflammation, from viruses, and there may be a component of left heart disease as well. And so there's this muddy color of overlap that we see in so many of our patients. And so trying to tease out the contributions from all of these different factors is important so you can know how to best treat your patient. When I think about this and thinking about the different conditions we see, there are a lot of conditions that have varying degrees of overlap. Certainly, we see pulmonary vein stenosis with vascular disease and left heart disease. Certainly, BPD has a component of abnormal lung development, can have a lung injury component, can also have a component of left heart disease. And so for this talk today, I'm going to focus on just a few of these conditions. Starting with BPD, we'll talk a little bit about TBX4 and then trisomy 21. So BPD, of course, this crowd, I don't have to tell sort of how we think about BPD and how it's changed. This is really in here to remind me that, we're fond of the BPD definition here because it was described at Stanford. We just had a lovely one-day research symposium on BPD, and we're going to have one again next October. So this is really my reminder to say, mark your calendar and come join us in Palo Alto next October. And getting into the phenotypes of BPD, of course, we see, I really like this paper from the group at CHOP a few years ago, looking at the different phenotypes of BPD, kids with airway disease, kids with lung disease, kids with pulmonary hypertension, and all the various contributions of these factors. And unsurprisingly, the more of these contributors you have, the worse your mortality and morbidity in terms of outcomes. And we see this all the time. There are kids who have much more of a vascular phenotype. So these were 2 24-weekers in our NICU, had a chest x-ray at 36 weeks. The one on the left had pulmonary hypertension on a screening echo. Lungs really weren't that bad. So falls more into that vascular phenotype or the pulmonary hypertension phenotype. The chest x-ray on the right obviously is terrible. You can see the breathing tube still there. This kid had really severe lung disease and probably a little bit of large airway disease as well. But shockingly, to my surprise, had no pulmonary hypertension on multiple screening echocardiograms. So how do we understand the contributors to these different phenotypes? And many of you are involved in research to try to understand these factors, but I think the more we learn, the more we realize this is incredibly complicated. There are a series of antenatal factors that can drive this. IUGR certainly is very important, maternal preeclampsia, chorioamnionitis, all these prenatal factors, by the time they see me, it's well out of our control. But there are postnatal factors, some of which we have control over and some we don't. Certainly postnatal growth, postnatal injury from the ventilator, from sepsis, and the impact that all of this has on the pulmonary vasculature is really quite complicated. We see abnormal vascular tone. Some kids respond to vasodilators, some kids don't. We assume from the imaging that we get that there's impaired angiogenesis in our patients, and certainly a reduction of the vascular surface area. And the interplay with the growing air spaces is certainly important in how these kids do long term. But despite all these insights from research, what we're left with when we approach these kids clinically is BPD severity. I mean, we really are looking at BPD severity as the biggest risk factor. And this paper is a few years old now from Drs. Marani and Admin, but I really like the way they put together several different cohorts by BPD severity, this stratification, and looked at the percentage of pulmonary hypertension in these 3 different studies. And you can see the black shading represents the percentage of kids with PH. And in the severe group, it's much more common. Anywhere from 30 to 60% of those babies develop pulmonary hypertension. But it's not the whole story. There's clearly many babies who didn't develop PH. And in the mild and moderate groups, and even a few without BPD ended up developing pulmonary hypertension. So it's not a perfect predictor, but it's often where we start. And so when we think about screening and how to approach these babies, I always go back and kind of look at our guidelines. We have the AHA ATS guidelines. Our Pediatric Pulmonary Hypertension Network in 2017 put out the bottom paper there with an evaluation and management approach to these kids. The European group, led by George Hansman, has put out a few publications, sort of global guidelines, and then also a more focused BPD paper. We have the 2022 European guidelines. These were mostly directed at adult, but included pediatric recommendations as well. And then this is the paper that Dunbar Ivy was the first author on from the most recent World Symposium this summer that just came out in August, that also has some management guidelines as well. So when we put all these together and think about how to approach the kids, I wanted to go through and compare a little bit, compare and contrast these guidelines. In general, they're all pretty similar and align nicely overall in terms of the big picture approach, but there are a few areas where they may have slight discrepancies. So generally, echo screening is strongly recommended by all groups. We all think this is important. There's a little bit of nuance here, I think, in how the recommendations have evolved over the years. The initial guidelines just said establish BPD. The European guidelines say establish BPD at 36 weeks, and the PPH-NET agreed with this 36-week timeline. You can see in green, both the European and PPH-NET papers recommended any kids who are really sick and still struggling with their lung disease. Those are kids we should probably continue to screen. And then the PPH-NET guideline included a consideration for those who continued to need ventilator support at day of life 7. So that early group that may be at higher risk for developing pulmonary hypertension later. And so how do the algorithms compare? The one on the left is from the PPH-NET paper, and the one on the right is from the European paper. In general, again, big picture is very similar. In terms of screening, the PPH-NET paper parses out sort of none or mild versus moderate or severe, with really focusing screening more on those kids who are higher risk due to their BPD severity. You can see there's some slight differences. The European guidelines specify starting sildenafil as a first-line agent, whereas the PPH-NET guideline doesn't specify therapies. And then both do have a mention of cardiac catheterization at some point, considering additional therapy. And again, the European guidelines specify using an endothelin receptor antagonist as the second-line agent, and then considering advanced therapies later. So there's a little bit of subtle difference there, but in general, they're very similar. And I shouldn't neglect this first recommendation here, which is really to optimize the lungs before you think about adding any PH therapies. So this is our algorithm here. Phil mentioned our CRIB program. We've been doing screening now here routinely since 2018. And we have sort of adopted the PPH-NET recommendations focusing on the more moderate and severe kids. We added in a consideration for kids who were born small for gestational age, even if they had mild BPD, knowing that those kids might be at increased risk. And we use NT-proBNP here, as well as echocardiograms for screening. We do continue screening monthly for kids who are on oxygen support longer term. And then Mike Tracy from Pulmonary and I have a multidisciplinary outpatient clinic, and we continue to see these kids. I screen them all with echoes at 6 months of age in the outpatient world. One place our inpatient algorithm may be a little bit different than some is that we end up doing a fair number of chest CTs here. I know Paul and the team in Cincinnati do a lot of MRIs in these patients. But for us, we end up doing a lot of chest CTs to look at the pulmonary vasculature, both to look for structural defects in the pulmonary arteries, as well as looking for pulmonary vein stenosis. It does often give us a sense of the parenchymal lung disease and sometimes airway abnormalities as well. So once we find it, then we have to figure out what's causing it. And so I like this Venn diagram that's, again, from Drs. Marani and Abman, thinking about the different contributors, from a physiologic standpoint in these patients. And I sort of put the groups here from that World Symposium classification to kind of help see how these factors line up. certainly we have a component of pulmonary vascular disease in so many of our kids, that abnormal vascular tone that may or may not be reactive to nitric oxide, with hypertensive vascular remodeling and thickening of that smooth muscle layer. And of course, impaired vascular growth is a huge problem for many of these infants. Of course, lung disease, the mechanical factors like hyperinflation and atelectasis, as well as abnormal lung function. And of course, group 2, that's left heart disease primarily, impaired systolic function or certainly diastolic function. And these, I think, especially the lung disease and the diastolic dysfunction, we are increasingly recognizing is so important to how we approach therapy. This I need to get on a t-shirt, because I'm constantly saying I can't fix the pH until we fix the lungs, because certainly this graph shows the vascular resistance as it pertains to lung volume, right? And this is PVR, the pulmonary vascular resistance, being lowest at FRC. So if you're too far to the left on that curve and you have low lung volumes from atelectasis, that capillary bed is going to be compressed and constricted, and your pulmonary vascular resistance is going to go up. Similarly, if you're on the upper end of that curve and your lungs are hyperinflated, those capillaries in between the air spaces are also going to be compressed, and your pulmonary vascular resistance is going to go up. And I can give you all the sildenafil in the world, but it's not going to fix that. So there really does have to be a focus on optimizing the lung mechanics before we think about pulmonary vasodilator therapies. I will admit, when I first started doing this, I wasn't as aware of the role of LV diastolic dysfunction in BPD and PH, but I'm becoming increasingly convinced. This can certainly be exacerbated by volume load from a left to right shunt. Certainly if there's left-sided outflow tract obstruction in kids who have congenital heart disease, say things like coarctation of the aorta. We think preemies are just inherently at risk for this. Their ventricles may be a bit more stiff than other kids. And so as a result, we can see worsening, so pulmonary edema, or just a fail to improve on inhaled nitric oxide. And Dr. Marani reported 2 kids in a case series some years back now. And you can see this nice X-ray image of the development of pulmonary edema with nitric oxide. That baby improved with the addition of diuretics and milrinone. So we wanted to look at that in our cohort here at Stanford. A recent fellow of mine, Rachael Sullivan, who's now at Vanderbilt, she looked at this data in a cohort of infants with BPD who underwent cardiac catheterization, and that was at an average of about 3 months of age. We use a definition, as I alluded to earlier, of a left atrial pressure or wedge pressure greater than 10 as our cutoff for abnormal. So we had 34 infants in this series, and about 32% of them, 11 infants, met our criteria for left atrial hypertension. And congenital heart disease was pretty common in the vast majority of these patients, some sort of shunt lesion. So when we went to look at risk factors for who had left atrial hypertension, it was the only risk factor that came out to be significant was being on positive pressure ventilation at the time of catheterization. These were kids who were on some sort of PPV at baseline, not during the procedure, because obviously most of them were intubated for the procedure. So we looked at things like sildenafil, we looked at things like type of congenital heart disease, degree of shunt, and none of that really came out to be significant. Obviously, it's a small cohort, but it got us thinking, if positive pressure ventilation is really the biggest driver, are we mistreating these kids? Are we not recognizing this appropriately? And is that left atrial hypertension causing pulmonary edema? And do we need to be diuresing these kids more? And is that why they continue to need, high respiratory support? Or the egg side to the chicken and egg question is, are these kids just sicker? And is it the sicker cohort of preemies who have more left atrial hypertension because their hearts are sicker and their lungs are also sicker? And so is it just kind of apples and oranges? And we don't have the answer to that yet. So I thought I'd go through a few cases of kids that we've seen here, and that may provide some nice examples of how phenotyping helped us manage these kids. So the first case was a 28 and 5/7 weeker, had a normal echo at 36 weeks, continued on a bit of nasal cannula, so got a repeat echo at 40 weeks and had new septal flattening. She then was able to wean to room air, was still on some diuretics, but was pretty tachypnic and had just started feeding by mouth. And you can see in the picture there, her flat septum, right? So the right ventricle on top, the LV here with that flattened interventricular septum. Case 2 was a baby who was a little bit older, almost 32 weeks, had a history of early PPHN that may have been a bit of a risk factor, but that had resolved. She was on CPAP after failing a wean to nasal cannula a few times, had a normal echo at 36 weeks, but because she was on continued on respiratory support, we got another echo at around 39 weeks, and she had new septal flattening, as you can see there in the image. The third case was a real micro preemie, 23-weeker, 440-gram birth weight. He was a twin. Unfortunately, his twin passed away, and so he was sent to us at an outside institution at 6 months of age for worsening pulmonary hypertension. He was on a high-flow nasal cannula, but really had a lot of signs of right-sided heart failure with hepatomegaly and an NT-proBNP that was over 6,000. And when we echoed him, his echo, as you can see in that image, looks worse. He had super systemic pressures with some bowing of his interventricular septum, right ventricular hypertrophy, and he had a bidirectional PDA consistent with elevated pulmonary vascular resistance. Okay, so we've now found pH. What do the guidelines tell us to do, right? Well, steps 1, 2, and 3, fix the lungs, fix the lungs, fix the lungs. And so looking at these guidelines, they all agree, as you can see in sort of the teal color that I've highlighted there, evaluation and treatment of the lung disease really has to be the first step. Looking for aspiration, looking for structural airway disease, making sure the respiratory support is optimized. And that's consistent across all 3 of these publications. The European group made a point to say, as you can see in the black highlighted there, that they would maximize non-invasive respiratory support as much as possible to avoid mechanical ventilation. And then in the red there, you can see the comments across the board on doing this before you initiate pH-specific therapy, which I think is really important. So what did we do with these kids? So this first kid, the one who had just started feeding, we got an X-ray and a blood gas, and those were fine. We ended up getting a video fluoroscopic swallow study that showed silent aspiration with oral feeding. And so we ended up sending her home with an NG tube. I saw her back in clinic a month later. Her echo had completely normalized. She ended up getting feeding therapy, was eventually able to wean off of her NG feeds and be fed all by mouth. And a year later, she had no pulmonary hypertension. I saw her a few times to make sure it didn't come back, but this kid did great, not hospitalized at all, growing, thriving. So eventually I had to discharge her from my clinic. But a nice point that silent aspiration is something to watch out for. Case 2, this was the slightly older baby who couldn't come off of CPAP. So we optimized her on CPAP, her echo improved. She failed weaning to nasal cannula, and this poor girl ended up in the hospital, intubated in our PICU multiple times that winter with every respiratory virus. She totally fell apart. So we got a CT scan, and she just had lung disease, really nothing remarkable. But our pulmonologist did a bronchoscopy and noticed that she had a subglottic membrane and severe tracheomalacia, so sort of explaining this positive pressure requirement that she had. And so she ended up being discharged home on a high-flow nasal cannula. Every time she got sick, she had pH on her echo, but every time we looked at her when she was well, she didn't. So she actually didn't end up getting any pulmonary vasodilator therapy either. And we followed her serially. By age 15 months, she was weaning on the nasal cannula. It had no pulmonary hypertension. And I actually just saw her, and she is now 2 years old, still doesn't have any pH by echo. So she's another one that I'm sort of running out of reasons to see as a cardiologist. The third case, the micropreemie, this baby had chronic CO2 retention. So we tweaked the nasal cannula, added some diuretics to treat the right-sided heart failure. Ended up getting a chest CT that showed ground glass opacities, some cystic changes, but no pulmonary vein stenosis, no other vascular abnormalities to explain the high PA pressures. And so we started him on some sildenafil, and his exam got better with the diuretics. His liver wasn't so big. He was breathing more comfortably. His NT-proBNP normalized, but his echo just never got better enough. His RV systolic pressure was still quite high. So going back to those guidelines, what do we do now, right? So we've done some therapy, we've optimized the lungs. Now it's when we have to think about cardiac catheterization. And so as you can see in blue there, kids who are clinically deteriorating probably have bought themselves a cath. In the red, if you're thinking combination therapy, you should probably think about cath. And then certainly in the sort of teal color there, concerns for vascular abnormalities, especially, keeping pulmonary vein stenosis in the back of our minds. You can see evidence of that by CT scan for sure, but cath would certainly be a gold standard for ruling that out, or if there's any suspicion by other imaging modalities, it's worth doing a cardiac cath. So we took this baby to the cath lab, and you can see his hemodynamics were quite elevated. That mean PA pressure was certainly greater than 20 at 49. He had a little bit of a left to right shunt under anesthesia from his PDA, and his pulmonary vascular resistance calculated out to be 8 index Woods units. And the ratio of his PVR to SVR was 0.6, with normal being less than 0.3. And you can see the angiogram there. There's not a lot of blood vessels there in this kid, just diffusely small, underdeveloped lungs, and really, I think sequelae of his extreme prematurity and growth restriction. So we added bosentan, and his echo sort of gradually improved. And after about 3 months in our NICU, he was able to go home on supplemental oxygen. By the time he was 18 months old, he was weaning off of oxygen, actually doing well, growing, thriving, still on dual pulmonary hypertension therapy, but his echo now had a rounded septum, and he had a small PDA with a gradient of 70. So that tells me his PA pressure was 70 less than his systolic blood pressure, which is great. So I weaned him off bosentan. His echo was unchanged, still active, playful, thriving, no symptoms, made it through the winter without any hospitalizations, tolerated his colds, came off of all supplemental oxygen. So now he's 2.5. And I'm thinking, well, do I stop the sildenafil? Do I not? His numbers were so bad on the first cath that I thought we better check again, even though his echo looked good. And I'm glad I did, because even though his echo looked great, his RV pressure wasn't normal. It was about half systemic. His mean PA pressure was still a little bit elevated at 26, with a pulmonary vascular resistance around 5. So he again had a little bit of a shunt. We closed his PDA because we were there and we could, but I don't think it was causing too many problems. And I've kept him on sildenafil. And so I think in talking to his parents, I think, and remembering that angiogram, he just needs to keep growing. He's making progress and his lungs are growing, but I'm not sure, the therapies we've given him have helped, but in general, it's really time, growth, and protection of the lung, I think, and I'm hoping he'll continue to improve as he grows over time. But there are those kids who just don't behave like they're supposed to. And so when do we have to think, gosh, is this more than just BPD and prematurity? And so I like this table here of developmental lung diseases associated with pulmonary hypertension from the most recent World Symposium that talks about all of the things that we know and love, BPD, CDH, but also some of the things that we maybe think about a little bit less, some of the more rare genetic causes. And we'll talk a little bit more about TBX4, but this paper from Nidhi Varghese and the PPH-NET showed some nice histology on the right, normal lung there in the first panel. Alveolar capillary dysplasia is something that we're increasingly recognizing as having an atypical phenotype, kids who can survive longer, as well as TBX4, which is a relatively new genetic condition. And when I was thinking about some of the kids we've had recently, I have a 15-year-old who was a 32-weeker, and for years he was diagnosed as just having BPD-PH. But he also has a history of Hirschsprung's disease, and one of our astute fellows said, I know this is weird, but could he have ACD? And sure enough, he has a pathogenic FOXF1 mutation. He's 15 years old and he's doing okay, but he's on oxygen and triple pH therapy. So he's a little bit of an anomaly there with ACD. We also have a 12-year-old who had a history of in utero drug exposure and kind of this PPHN that never resolved and continued to be an issue for her over her life. And it turns out when we finally did genetic testing on her, she has a TBX4 variant. So things to keep in the back of our minds as we see these kids who just don't get better. So a little bit on TBX4. This is a gene, as you can see in the timeline here, that, of course, as we all know, it causes small patella syndrome. That was described back in 2002. In 2013, we saw that this was associated with pulmonary hypertension. A group in the Netherlands first published that. And as we've learned more about this gene, we've learned that it really causes a whole spectrum of developmental lung diseases. This is a nice paper from Chapagalombos and colleagues showing the spectrum of disease. You can see the X-rays and CTs there with really, kind of a spectrum of severity in terms of developmental lung disease. And then the pathology on the right showing some underdeveloped respiratory lobules in the lung, as well as pulmonary vascular remodeling with medial hyperplasia and that intimal proliferation as well, similar to what we see in group 1 pulmonary arterial hypertension. And so these kids end up having features of group 1 and group 3. It's not uncommon for babies to present with this as PPHN that just never gets better. There was a recent French study from a few years ago that actually saw a bimodal distribution. Their median age at diagnosis, and this was mostly in families who carried it, was a younger age. The median age was 29, but sort of a younger cohort and then an older group. And as I think the adult world starts doing more genetic testing, they may stumble across more patients with TBX4. 80% of them can have skeletal abnormalities. The biggest one are knee problems, but they can also have some toe and long bone abnormalities in the femur as well as the hips. Half of the patients in this cohort had restrictive or obstructive lung disease, all with a reduced DLCO. High-res CT showed a number of airway abnormalities, mostly bronchial abnormalities, but also lung parenchymal lesions and mediastinal lymphadenopathy. And so we have a lot more to learn about the spectrum of this disease and the impact it has on pulmonary hypertension. But you can see in the histology there, the yellow arrow pointing to a severely remodeled pulmonary artery. And I just want to make a plug for this group called TBX for Life. It's tbx4.org. This is an organization that was started by the father of a child with TBX4, and he has amassed a group of experts. He's really promoting research and education in TBX4, and it's a fantastic group. So if you're at all interested, please check it out. They also have a lot of resources and support groups for families as well. In the last few minutes, I'll just touch on trisomy 21. Because I think this is another category that highlights the importance of phenotyping and the importance of identifying and recognizing comorbidities that can contribute to pulmonary hypertension. So of course, congenital heart disease and shunt-related physiology is so important in kids with trisomy 21, and it contributes to pulmonary hypertension from that chronic shear stress that causes endothelial dysfunction. Obviously, there's an inherent genetic risk with altered angiogenic factors, increased circulating biomarkers of pH, as well as the structural lung and airway abnormalities. And the prior World Symposium actually recommended that in the absence of a clear congenital heart disease etiology, that these patients be classified as group 3 developmental lung disease, pulmonary hypertension, because we are increasingly recognizing a component of developmental lung disease in babies with trisomy 21. Obviously, airway obstruction can be an issue, and lung damage and aspiration from abnormal feeding and aspiration concerns is certainly important to recognize as well. And this figures from a recent review article by Drs. Bush and Ivy that kind of nicely highlights the interplay between the hemodynamic stress, the PVR, and the pulmonary arterial remodeling that we see in the vascular bed of kids with trisomy 21. So our Pediatric Pulmonary Hypertension Network registry contained about almost 1,500 kids with pulmonary hypertension, primarily in the US and one Canadian site. And so we decided to look at the subset of kids with trisomy 21 in our registry. And so we found 158 kids with PH and trisomy 21. That was 11% of our total registry, so a pretty substantial proportion of the kids we see. And interestingly for this group, the median age at PH diagnosis was 6 months. So the vast majority of the kids that we follow who come to us with pulmonary hypertension are diagnosed in infancy. And the comorbidities, it was really striking to us how common they were. Congenital heart disease was present in 95% of the kids that we saw. About 2/3 of them ended up undergoing surgical repair. Sleep apnea was also in more than half of the kids in our group. Prematurity was also common, as was GE reflux, aspiration, and recurrent respiratory exacerbations. So really a strong contribution from congenital heart disease as well as airway and lung abnormalities. And so when we went to say, okay, overall survival in these kids, actually pretty similar to that in the registry as a whole. It was about 88% at 5 years, which we were pretty happy with. But we wanted to dig a little deeper and see, well, which kids actually get worse? And so we created a composite outcome of severe pulmonary hypertension, combining death, being functional class 4, so pretty limited in terms of what you can do, needing a hospitalization for pulmonary hypertension, or needing a continuous prostacyclin therapy. And that outcome was met in about 1/3 of the kids in our cohort. And the risk factors for this were actually having a tracheostomy and having reflux that was treated medically. So it was a bit surprising to me, to be honest, but I think the conclusion that we made from that is that reflux and aspiration is probably important, and certainly lung disease that's severe enough to require a tracheostomy makes these patients much higher risk. But on the flip side, many of these kids got better. So about 1/3 of kids had resolution of their pulmonary hypertension, which we defined as being able to come off of pulmonary hypertension medications. About 1/3 of them had resolution of disease at 1 year, and 43% had disease resolution after 3 years. And the biggest sort of risk factor for this resolution was being diagnosed at age less than 6 months. So again, this developmental phenotype that I always think about, it's kind of PPHN, but in many of these kids it lasts longer than, what we typically think of as PPHN, but certainly a developmental abnormality that these kids are able to overcome with growth and protection of the lung, which is really encouraging to us to see these kids get better over time. Interestingly enough, a pre-tricuspid shunt was also protective. We kind of had to scratch our heads a little bit, and honestly don't have a great explanation for that. But in any case, it ended up being significant. So in the last few minutes, how do we approach treating these kids? I told you a little bit about the cases and walked through that, optimizing the lungs first, fluid status, addressing shunts, pulmonary edema. And I love this quote from Brian Hanna, who I worked with at CHOP. He used to always say, well, you can't dilate what isn't there. And that's really the problem with so many of these kids. There's not enough blood vessel there. That said, we try to optimize the vessels that are there, and we use pulmonary vasodilators pretty widely. We don't have approval from regulatory agencies. We don't have large randomized controlled trials, but we do the best we can. And this figure at the bottom here shows you over time the incredible increase of sildenafil use in NICUs. On the left there is by year, and then on the right shows you by gestational age, and the vast majority of the use is in these preemies. And I didn't, in the interest of time, get too into the weeds in terms of the different studies showing, improvement with pulmonary vasodilators. But on top, there's a table from a meta-analysis of different studies looking at sildenafil in kids with BPD and pulmonary hypertension. And the vast majority of studies had improvement in the pulmonary artery pressure estimates. Some had improvement in respiratory scores. The figure on the bottom is looking at treprostinil use from the group at CHOP, showing improvement in BNP over time on the left graph, the middle showing improvement in TAPSE over time, and the right showing improvement in RV global longitudinal strain over time. So we do have evidence to suggest that these drugs help our kids, but I'm always humbled. So just a couple months ago, I had a patient sort of prove me wrong, and this just highlights the fact that patient selection is so important, and there are just some things that we don't know. This was a 4-month-old 25-weeker who had a flat septum on echo. You can see her x-ray there on the left, clearly has bad lung disease. We got a CT scan, ugly cystic lesions, but she was doing okay on a high flow nasal cannula at about 35% FiO2. So in my mind was not a huge setup for having a VQ mismatch. But you can see in that graph on the right, I put her on some sildenafil, and her FiO2 requirement gradually climbed up over the next 10 days or so. And so I had to stop and say, gee, are we worsening VQ matching here by giving her sildenafil? And I do think that some of these kids really would benefit more from inhaled therapies, but they're just so hard to give. So we do have some inhaled therapies in the adult world, and I'll get to that in the next slide. But we don't have a great way to give them in babies long term. We can certainly give inhaled prostacyclins through a ventilator, through an ET tube, but we don't have a great way to give these therapies to kids long term, and certainly not as an outpatient. And that's because the devices actually require patient participation. You have to inhale either a dry powder or be able to use an inhalation device. And so they're just really not designed to be used in infants. And this quote is from that recent World Symposium paper where they said, favorable effects of these therapies are expected in patients who have more severe pre-capillary disease and mild lung disease. And so the increase in PVR is mostly associated with the presence of pulmonary vascular disease, which is true. But unfortunately, the vast majority of the kids that we see are like this kid. They have bad lung disease and they have bad pulmonary hypertension. And so do we try these agents in these kids? Most of the time, yes, but it doesn't always make them better. And just a word on, from the lung disease, pulmonary hypertension spectrum in adults is obviously a different ballgame. Adults have very different type of lung disease than our infants do. This table is from the most recent World Symposium, shows the summary of trials in COPD, ILD, idiopathic pulmonary fibrosis, and PH associated with those conditions. And I've marked in green the studies that showed benefit, yellow was the studies that were equivocal, and red were 2 studies that were terminated for clinical worsening. And so you can see there really isn't a great consensus about use of pulmonary vasodilators in these kids. But there was a study of adults with interstitial lung disease associated pulmonary hypertension. And you can see the change from baseline in terms of their 6-minute walk distance, significant improvement in the group who got inhaled treprostinil versus placebo. So I think in the adult world, at least in PH associated with lung disease, inhaled therapies are now becoming the preferred approach. And I'm hoping that we'll have more options for that for kids in the future. So I'll wrap up by saying that, of course, we recognize the role of disordered lung growth and development is critical and impacts our disease phenotypes significantly. We have to continue to be precise in our phenotyping of these kids to really understand the drivers of disease and to tailor our therapy. At the end of the day, we use pulmonary vasodilator therapies, but it's really not the right approach. What we really need are precision therapies that help us correct abnormal development or promote vascular growth if we really want to be able to help these kids better. So with that, I will say thank you and certainly look forward to an interesting discussion and any questions that you have.
Thank you, Rachel. That was incredible. I mean, just by the sheer number of questions we're getting in the Q&A already, just a phenomenal way to present it and way to think about it, all the way from screening to phenotyping to diagnosing to cath to management. And we're going to get into all of that over the next half hour or so. So thank you. I'm going to now just introduce our 3 other panelists, and I see that their cameras are on. Awesome. And then we will kind of rotate. And please continue to ask your questions in the Q&A. But really, just my privilege, an honor to also welcome Amish Jain, who, beyond being one of the founders of the Neonatal Hemodynamics Research Center, is a neonatologist and professor at Mount Sinai Health System in Toronto. He has tremendous amount of research interest, but a lot of it ranges from critical care to functional echo to neonatal cardiopulmonary physiology and chronic pulmonary hypertension. And hopefully he'll talk about some of his latest research. We also have Soume Bhattacharya, who is a neonatologist and director of the T&E program at London Health Science Center. She also has many interests, and I've crossed paths with her both on our work with cardiovascular care, pulmonary hypertension, and preterm brain injury. And finally, really just a pleasure to have another pediatric cardiologist, Paul Critser, spent a lot of time in Boston over the years, but now has found a home and landing spot in Cincinnati Children's Hospital. And his research actually is really novel, using MRI, lung disease, pediatric pulmonary hypertension, congenital heart disease, and a lot of developmental lung disorders. We're just really excited to have all of you. I'm going to really just kick it off. Rachel, I'm going to throw it back to you. There are so many questions in this Q&A, but I want to start off, one of the ones that keeps popping up, and this is a little bit unique to Stanford, some of the other centers. I see that you guys use BMP in your kind of screening. I think people want to get a better understanding of how you use that in terms of your screening, maybe your phenotyping, maybe your treatment modalities. And then can you just end a little bit with, what are some of the new exciting treatments that you've been involved with, different studies, maybe things that are happening in the adult world that you're bringing into the pediatric world, because there's a lot we need to learn from you. And again, thank you so much for that great talk.
Yeah, my pleasure. There are a few, so when I was at CHOP, they used BNP frequently, weekly, sometimes daily in kids. And so it was something that I learned to incorporate. That said, I have a fellow looking back at all of our echo and NT-proBNP screening here at Stanford from the last 6 years or so. And the correlation in our hands between NT-proBNP and echo evidence of pulmonary hypertension isn't actually great. But I think we have to remember, what does BNP tell you? It's a marker of stretch of the heart, right? So it can be stretch of the LV, it can be stretch of the RV. Oftentimes I see it in babies who are fluid overloaded, and these may be babies who have diastolic dysfunction, or it may just be general fluid overload. It certainly can reflect changes in pH severity. Trending over time certainly can be helpful, especially if kids show up in right heart failure. So for me, that's the most helpful population when you're really worried about ventricular dysfunction and trying to get a baby out of right heart failure. You can do frequent echoes, but the NT-proBNP is another helpful non-invasive marker to trend over time to see if you are actually being able to improve things. And I saw there was a question about sort of the normal ranges, and it's my understanding from talking from some people who do biomarker work that BNP is actually developmentally regulated. So some hospitals have age-specific normal ranges. At our hospital, NT-proBNP up to 1,000 is considered normal in an infant, whereas under 300 is normal for an adult or older child. So there probably is some relationship to age and what is considered normal. We don't have norms for preemies, so it's not uncommon for us to get a screening BNP that's around 1,500 in a preemie, and then their echo is normal. And so I don't know if that's reflecting maybe some mild subclinical pulmonary hypertension or a little bit of LV diastolic dysfunction that's not overtly apparent on the echo, or if it's just that the normal range for a preemie is closer to 1,500. I don't know. But certainly the more severe pH cases, I do find it to be helpful to trend over time. I'm not totally convinced that it's the most helpful screening tool, but would be curious to hear what others have to say. Do you want me to launch into other therapies now, or do you?
No, let's save the other therapies.
Well,
I think Rachel's going to ask Amish some questions along the lines on this same theme.
Yeah.
So Rachel, take it away.
Yeah, thanks. And Dr. Hopper echoing Phil's comments. That was a fantastic talk, so thank you so much. Dr. Jain, so in Dr. Hopper, she was, outlining that there's several guidelines out there. There's some algorithmic approaches, but, what are your thoughts on, as she was highlighting all the phenotypic differences that there are in chronic pulmonary hypertension, do you kind of buy into, do you have an algorithmic approach that you use? Are you kind of being really specific about each individual's baby's echo and care? And then second part of that question, on the algorithm of just screening for pulmonary hypertension, can you talk about the extremely preterm babies and whether you think we're kind of missing earlier diagnosis when 36 weeks corrected is a couple months of age for some of those kids?
Yeah. Well, first of all, let me congratulate Rachel on that fantastic talk. I actually learned quite a bit from it. I do pretend to be a pediatric cardiologist, but I'm not. So you clearly showed why I'm not. So thank you for that. And then also the echo, the NT-proBNP part of things, can't agree more. I think it's not, in my view at least, we've been doing it for a few years now. We don't do it as a screen at 36 weeks, but once we establish the phenotype, then we start monitoring it. And every year, my trainees ask me the same question, and I tell them that it's not exact science. There's a degree of art to it. So you will have to build up your experience to be able to use it effectively in patient care. You just can't come up with a cookbook recipe to use it currently. We've tried looking at the same thing, Rachel, as you were saying. Last year, we presented the work at PAS that looking at the echo and NT-proBNP paired, and we could not find it to be a very good screening tool. But once we have established the pH and we established that there is no other marker like volume overload, it seems to go very well with the severity in terms of sequentially. So I use it to spare maybe an echo here and there. So sometimes use it instead. So that's that. Coming to you, your specific question, Rachel, I mean, you bring up very important points, and honestly, we don't completely know, and I'm going to order them in reverse order. In terms of timing of screening, I mean, that thing has come out in some review articles, and thought-provoking questions have come up as we are doing less and less, and more 22, 23-week babies, now even 21 sometimes. And the question becomes, when do we screen? And the short answer is we don't know. I think the question is valid and we need to study it. Should we screen earlier? I have tried to stay away from it as much as possible, and simply because we don't know. You know, a lot of my colleagues just anecdotally have asked me sometimes to look at 32, 31 week corrected age because the kid is on respiratory support. The trouble is, at that time, being on respiratory support is not abnormal clinical sign. So how do you distinguish symptomologic pH versus just a kid who needs to go have a bit of lung growth? And even when I have found flat septum based echo diagnosis, we have never treated them early because almost none of them had RV dilatation. Occasional kid does come through where they have what we think is congestive right heart congestion, but most of them don't, and they progress over time. So I've not implemented that yet, but I think it's an important question we should examine for sure. Is it a postnatal age effect, or is it a corrected gestational age where it becomes symptomatic? But my worry is that we start doing it clinically because it makes sense to do it at 8 weeks of age or 32 weeks that people are proposing. You will find flat septum, you will start treating it, and we would still never know when really we should be looking at it. But it does go with the severity of lung disease. So kids who are on 50-60% oxygen on a ventilator after 6-8 weeks of age, we do tend to sometimes look to make sure it's not contributing to the phenotype. Not so much a non-invasive respiratory support kids. We wait them out a little bit longer, give them some more time. I'm not sure whether I answered your question or made it more confusing. But
No,
I think
that was helpful, Amish. I think along those same lines, and Paul, this is going to be throwing it in your boat. You as the neonatologist, or if you're not working in a center that has a hemodynamics clinician, we have these screening protocols and we order the echocardiogram, and then we really rely on people like yourself and Rachel to interpret them. So it's really a twofold question that's come in the chat. It's broad stroke categories. How do you think about the echo and its findings and the categories to help you determine the phenotype? And then along those same lines, since you've done a lot of work with MRI and BPD and pulmonary hypertension, how are you thinking about infusing the clinical perspective of the MRI into helping the phenotypes and then helping the long-term management? And just thank you for being here today.
No, absolutely. It's my pleasure. And, I think both of those questions are sort of complementary. We use heart and lung MRI routinely in our BPD infants between really 36 and 40 weeks PMA. And it's incredibly helpful for us to phenotype those patients. As Rachel talked about, there's those overlapping components of parenchymal lung disease, airway, and cardiac or vascular phenotypes. And that MRI gives us a lot of good information about all three of those categories. It also has been very useful in prognostic information for both us as clinicians and for families in terms of predicting how long patients might need mechanical ventilation, likelihood of need for tracheostomy, and likelihood of need for pH therapy. From an echo standpoint, I think the most important part, as Rachel alluded to, is the initial echo really needs to be a complete anatomic assessment. Make sure you're looking for pulmonary vein stenosis, other anatomic issues, evaluating for diastolic dysfunction, which can be challenging in preterm neonates. And then on subsequent echoes, a lot of the focus is on categorizing the degree of RV hypertension, the degree of RV function or dysfunction, any particular shunts, and again, trying to get insight into that potential LV diastolic dysfunction, which can really impact the decision of whether you're using pulmonary vasodilator therapy or agents to try and afterload the left heart.
Thank you. And maybe Dr. Bhattacharya, I'll direct this one to you, but anyone can jump in as well. But there's several questions in the chat about specifics of echo-based diagnosis and having built an HD program. Like, do you have strict criteria, and are you phenotyping each of your echoes? And there was a question about specifically the post-capillary phenotype, but if you want to talk about more generally, just how are you diagnosing if you're not able to go to cath, what are you using?
That's a great question. Thanks, Dr. Hopper, for an amazing talk. And thanks, Phil and Rachel, for having me here. So in pertaining to that question, and I think that's very relevant for specifically hemodynamic trainees, because the guidelines are giving us a definition of pulmonary hypertension based on cath. And we don't have that. All we have in most of the centers, not the lung heart MRI, we have an echo. So in our institute, we have instituted a protocol of when we are screening them and what exact tools or what exact echo markers you're using to diagnose it. So as Amish said, it's mostly at 36 weeks when they have a diagnosis of BPD. And in the echo, really, at that point of time, at 36 weeks, you're really looking at indirect markers, right? You're not getting an exact PA estimate. So we are looking at your septal flattening. We are looking at your PI, the TR, and any of the shunt, especially the PDA shunt. From the septum perspective, eccentricity index we are using, and then again complementing it with a very thorough assessment of RV, both RV size as well as RV function. There'll be diastolic function. Yes, we try it. It is tricky. It is tricky to interpret. A little bit of emphasis on the importance of getting good quality images. So I always ask the trainees that, you know what, like, please do spend some really good time in getting your nice septal images in the right axis, because ultimately it might be all that you have to diagnose, or because, they may not have a TR that is giving you a great envelope. They may not have a PDA. I think just that extra time spent in getting good quality images helps a lot. Going back to what Dr. Critser said, I think the assessment of pulmonary veins is very important. I think especially when a baby is persistently demonstrating worsening pulmonary hypertension, by protocol, we have made it mandatory to assess pulmonary veins at 36-week scan with Dopplers. Not only color and 2D images, but basically Doppling each of the 4 pulmonary vein and then doing the R2R tracing to have a mean gradient. And then again, subsequently following it, because, even we have found babies, we have cleared the pulmonary vein at the 36 weeks, and they are still really struggling at 44 weeks. You need to go back to the pulmonary veins. I often feel like as neonatologists doing an echo, and really being the only people who are following these, because these have anatomically normal hearts, it is very important to take that extra, cautious approach and be very diligent in your imaging. And the last thing I want to mention is, again, a big part of our protocol is the shunt assessment and the atrial level shunt assessment. Again, traditionally, cardiologists in our center 5 years back wouldn't really worry about the atrial level shunts. But I think time and time again, I think we are showing that you have a 23-weeker with moderate to severe BPD and, has a moderate ASD, they really struggle with the atrial shunt, and they start showing their RV size changes. Those are the good side of this is, yes, they struggle with atrial shunt. The good part is they do respond very well with diuretics. And I believe, I'll probably turn the question back to Amish, from whom I learned how to use diuretic, as whether if he can discuss a little bit of how he uses diuretics in this population. I hope that answered some of your question.
Amish, you're up.
My simplest thing is that if I use diuretics, I'm allowed to be a dummy then. I don't need to distinguish the LV phenotype and the PVR phenotype and the volume shunt phenotype, because the end product still is pulmonary edema for symptomology. So by using diuretic, I'm basically trying to avoid having to label the patient into different phenotypes. And those who respond very nicely, then, it makes you feel good that you improve clinical care, but I still don't know how many of them had actually shunt physiology. But I agree. I think all of us will agree, having looked at these kids more closely, that these kids don't tolerate their PFO or AST shunt very well. And many of them at a smaller level seems to have more symptomatic RV congestion. And as Soume said, the good thing is that they grow out of it very quickly. Is the pH, which they don't grow out that easily. But as the lung grows a little bit, the pulmonary vascular capacity grows. Same PFO or ASDs are no longer symptomatic after a few weeks. And those are the ones that have they respond very nicely to diuretic, and you don't need long-term diuretic for those scenarios. But that phenotype exists. And so from us, diuretics is our first step of treatment before we go to pulmonary vasodilators. And not because we can't distinguish, but because for the fact that Richard was saying that these kids have time and lung growth on their hand. So if you can make them asymptomatic, treat the pulmonary edema effectively, the expected course is that they will get better and over time. So we try to minimize off-label use of therapies that we don't know exactly how much to use, and the fact that it can worsen their reflux and worsen their VQ matching in some cases. We try to use that, and only when diuretics therapies don't work and the kids are still symptomatic, then we really hone into phenotype. Do we really think it's a PVR phenotype? Do we really think this is a left heart phenotype and or a shunt? Usually they are PVR phenotype that we end up trying to give sildenafil, and there are times we are sitting on the fence. So that's how we tend to use diuretics primarily, and monitor with NT-proBNP. Every year, I mean, our center is slightly different, like unlike I think from both Paul and Rachael center, they probably are referral center as well. We are an in-house hardcore extreme preterm center where we are mostly inborn, probably the largest in Canada for extreme preterms. So our patient population is sort of, it doesn't comprise of kids who are coming out from outside. So we don't have a lot of CDH or trisomy 21 kids or kids who's already had horrible lung disease. So within that context, I would say out of 150 kids that we have less than 28 weeks every year born in our hospital, we end up using sildenafil about 4 times a year. Not more than that. And I just 2 weeks ago was the first kid I started on bosantan, for which I'm going to actually have a question for Rachael for that. So one question I want to know from my side, because I really struggle with the LV phenotype. There's a lot of debate right now in literature about LV diastolic phenotype or post-capillary phenotype, contribution to BPD and contribution to CPH. How I cannot examine an echo and say, yeah, you have LV diastolic dysfunction, which is clinically relevant. I'm just not able to. The only time I've made that qualitative judgment is the LA is big and there is no reason for it to be big. There's no PDA, there's no VSDs and the LA is large. I presume it's because of LA pressure overload and which contributing. But you guys do a cath. So when you were showing your data, Rachael, you saw LV phenotype or LAD present in what 15% of cases. Are there any echo markers in those patients that were different that could help us understand which echo markers to actually try? Or
we didn't go back and look at it specifically. And as a cardiologist who's not an echo person, but certainly went through that training, I think it's really hard. I agree with you. I know some people, really focus on those markers of diastolic dysfunction, but it's not a perfect science, especially in kids, when they're on the ventilator and you don't have great echo windows. And I struggle to hang my hat on a number of those echo markers. And really, I think if you're concerned, cath is the gold standard, and obviously we want to avoid that if at all possible, for all of the reasons of avoiding an invasive procedure in a small baby. But there are times that it's helpful. Certainly shunts can contribute to that as well. So there are times when, even though the PDA may not look that big, some of the kids in that series were kids that we took to cath to see, okay, are we missing a big shunt? And maybe if we close this duct, will that help? And some of those kids were the ones who had a bit of diastolic dysfunction, presumably being related to not being able to handle that extra volume load. So I think there are times when cath can be really helpful in these patients. And probably people who are more in love with echo than I am will have a different answer than I don't know if Paul has a different thought, but I find it hard to really hang my hat on that. And as you sort of alluded to before, trying diuretics rarely hurts in these kids. So if you see a clinical improvement, certainly in the degree of pulmonary edema and the left atrial size, then you almost have your answer there too, and you don't even need the cath.
Paul, what do you think about LV dysfunction? How do you think about that?
Yeah, I would agree. It's in the immature neonatal myocardium, kids with challenging imaging windows, it can be hard to rely on our standard echometrics for mild LV diastolic dysfunction. I will say in particular, I think it's important in kids who have significant RV hypertension, systemic plus RV pressures, but have left to right shunting at the atrial level. To me, that really is a marker of diastolic dysfunction and should make you think very carefully about using pulmonary vasodilator therapy, which may just drive more LA hypertension and pulmonary venous congestion. And in those patients, you may be better off with diuretics or with afterload reduction. That I think we see most often in the CDH population, who often have some mildly small left heart structures and can be very important in those kids.
Yeah, I mean, you made a really nice point, Paul, that the AST shunt physiology in the context of CPH or context of chronic pulmonary hypertension may give you some idea. And the challenge for me becomes, is the ASD shunt driving, if it is left or right, is the ASD shunt driving the pulmonary hypertension, or the LV dysfunction is the main reason driving both? And I don't know what your experiences. I find the shunts are far more common in this patient population with diagnosed with PH than we ever would have thought in the past. And a lot of ASDs are left right.
And I think if you have more mild RV hypertension, that's what we expect, is usually you'll have left to right shunting. And in that case, that increased pulmonary blood flow can drive some of the lung disease, can worsen the pulmonary vascular disease. And we've had a handful of patients over the last year or two where we've struggled with those questions. We've taken them to cath, or we've done an MRI, and we've seen that the atrial level shunt really is more significant than we thought. And when we've occluded that ASD, things get significantly better, both the pH and some of that LV function.
Great. We have 5 minutes left, and we spend a lot of time on these hemodynamics webinars talking about echo and all these novel ways to phenotype using echo. We don't spend as much time on the actual treatment. So Rachael and Paul, I'm going to throw it first to Rachael, then to Paul. I think, you talked a little bit about bosentan and a little bit about sildenafil, but I think it would behoove the group to just hear about some of the novel therapies that are coming out that may obviously not be approved yet in our extreme premature infants, but have potential for the future. And really just want your overall thoughts of where the field is and where it's going.
Yeah, thanks. I didn't go into the details of the pulmonary vasodilators on the market now, just because I don't use the vast majority of them in infants. We tend to use sildenafil as our first line, bosentan as our second line. For kids who are in true right heart failure with severe disease, we tend to use treprostinil. Sometimes we'll use inhaled epoprostenol. But the other therapies I'm a little cautious to use in young children, just because we don't have a lot of data about dosing, about pharmacokinetics, about safety. They just haven't been as well studied. So, some units, and I saw there was a question in the chat about tadalafil. Some places do use tadalafil in infants. We don't. It's very similar to sildenafil, but is given once a day in adults and older kids. So for all of my school age kids, I try to have them on tadalafil instead of sildenafil, just for ease of dosing. Similarly, the ambrisentan and macitentan are once a day endothelin receptor antagonists that don't require the monthly lab monitoring that bosentan requires. So for many reasons, I have kids, I use primarily ambrisentan in the outpatient world for older children. But again, there's just not a ton of data. There was some early animal data that raised some concern. Animal data, and I think it was in rats, some concern with tendons or something for ambrisentan in neonatal animals, and it was from a long time ago, and it probably isn't something to worry about. But for those reasons, I think many of us have been slow to embrace some of these newer drugs, really in our infant population. And we have to remember that these drugs were all designed for pulmonary arterial hypertension, which some of our kids have, but it's really, has not been well studied in infants with lung disease. I think the prostacyclins are tremendously helpful for kids who are in a lot of trouble, who are in florid right heart failure with severe pulmonary vascular disease. And we've had a number of kids do really well on subcutaneous treprostinil chronically. In terms of new therapies, the newest one for us that's kind of the hot topic in the PH world for the last few years is a drug called sotatercept, which knocks down activin signaling in sort of an attempt to rebalance BMPR2 and activin signaling because BMPR2 is known to be depressed in patients with PAH, and many of our patients have BMPR2 mutations. That hasn't really been studied in adults with lung disease yet. It's only been studied in pulmonary arterial hypertension, that pure group 1 phenotype. So it's not clear to me yet how much that signaling pathway plays a role in the pathogenesis of disease in this infant population. And so if we get to the point where sotatercept would be considered a therapy for those kids, I think we're still a way off. It's also a subcutaneous injection that's given every 3 weeks. So it may not be the most ideal therapy for young kids in general, just from the practicality of sticking kids so often. There is a pediatric trial for children with group 1 PAH, and I know we're involved in that, and I think Paul's been involved in that as well. So at least hopefully learn more in the coming months about the right dosage and have a little bit more experience in pediatrics going forward. I don't know, Paul, if you want to add anything to that.
I think we have a very similar clinical practice in terms of our choice of pH therapies for infants. I will just add, I think sotatercept for us is very exciting because it's the first in what we expect will be additional sort of biologic agents. Sotatercept does have a side effect profile, some off-target effects, including development of telangiectasias and some bleeding risk. And already they think they have some understanding of why that is and are developing new agents that are more selective and hopefully will have a better side effect profile. So I think there's a lot of excitement from our community about new agents that will be developed over the next 5 to 10 years.
Wow. Thank you all so very much. I know there's a lot of questions that have been answered or still yet to be answered in the chat. We'll work through all of those and try and get some of those answers out to everybody. This has been just an extremely informative session where I think we've learned, the thought processes to screening, the use of the different diagnostic and biochemical modalities. Rachel's taught us about phenotyping when we do identify pulmonary hypertension. I think some of the take-home messages, even with the discussions on the diuretics, is that when you do find pulmonary hypertension and you're phenotyping it, to try and optimize all of the non-pH, non-pharmacological management strategies with optimization of ventilation, oxygenation, diuretics, treat for infections. And then we've touched upon a little bit about different treatment options that are available and out there. I will highlight what's up on the screen. A lot of these topics will be readdressed at the Reagan Geisinger Clinical Cardiopulmonary Physiology course. It's the European version this year. It's going to be virtual the first week of November. I'll also highlight that a lot of these topics are also assessed at the San Francisco Pulmonary Hypertension Conference, which Rachael and Paul are frequent speakers at over the years. So with that, it's 15 past the hour. I want to thank Rachael specifically for sharing her words of wisdom. I want to thank Soume, Amish, and Paul for also sharing their insights about their specific programs, and thank my co-moderator today, Rachael Hyland, and then thank Laura Thomas and Megan from the NHRC. Thank you all, and we'll see you at the next webinar. Have a good day and a good night wherever you are. Thank you.